All right, today is March, the 2nd, 2021, and we're doing our review for the final in the oral. You have some pre-recorded lectures already in the module that space it out, I think it's A through F or something like that. They're already there. Okay, so just disregard the dates that I'm saying. Disregard any of the syllabus inquiries that I'm talking about on those pre-recorded lectures. Okay, so I don't want you to get yourself confused. But those are just some pre-recorded lectures of the final comprehensive review. Today, I'm going to start off with some ABGs. Okay, a lot of people have some issues with ABGs. I want to make sure you got that understanding, all of the concepts of it with compensated, uncompensated, all of that. Okay, so we're going to get started. When you have your answer, just put it in the chat. Okay, when you have your answer, put your answer in the chat. And then if you have a question on one, we'll do that. Okay, I may even call your name and tell you to answer it for us. You don't have to cut your camera on, but be paying attention so that we can be ready to answer. Okay, all right. All right, first things first, pH of 7.8, CO2 of 10, bicarb of 24, and a PaO2 of 85, right? On room air. All right. All right, work that out and then put that in the chat. This patient is on room air. pH of 7.8, CO2 of 10, bicarb of 24, and a PaO2 of 85. Remember our steps. First things first is to find out what is pH doing. Then find out who's causing her to do that. That is your second player. Then look at the third player, remember, and see, is he trying to compensate, yes or no? If he's in normal range, he ain't trying to compensate. He care less. If he is in normal range, if he is in normal range, then he's not trying to compensate. He could care less, okay? But if he is not in normal range, then he is trying to compensate. All right, so once you distinguish that he is trying to compensate, last step would be to find out, was his compensation or his pool, his gain, enough to bring pH back into normal range. All right, so I got a few answers in the chat. Good, Michael, excellent. Need everybody to put something in the chat. If you don't know, just type, I don't know. But I need everybody to put something. All right, so let me see here. Okay, Stephanie, that's correct. But you got one thing on the front. I need to know the compensation component. Let me know the compensation component, Stephanie. What's that? Charisma. Good charisma. Good, Kelsey. Okay, good, Stephanie. All right. So this one is First things first, find out what's pH doing. pH is 7.8, so we are in a alkalosis. All right, we know we are in the alkalosis. Right, now the next thing is to find out who's causing this alkalosis. Well, CO2 in this case is 10, so that's alkaline, right? Bicarb is 24, which is normal. So bicarb not causing the problem. The problem is CO2. So if CO2 is causing the problem, it's a respiratory problem. So we are in a respiratory alkalosis. All right, next step, finding the compensation component. All right, now, so in this case, CO2 happens to be the second player because he's the one causing the problem. So by default, bicarb is the third player. Now, is our third player in normal range? Yes. So that means there's no compensation. So that's uncompensated respiratory alkalosis. Then we finally look at our oxygen. A P little AO2 of 85 is normal. So with normal oxemia. So your answer should be uncompensated respiratory alkalosis with normal oxemia. All right. Let's look at another. Next up, pH of 6.9. A CO2 of 85. And a bicarb of 10. And a P little AO2 of 36. Take a moment to look at that. Put it in the chat. First things first, what is pH doing? Then who's causing pH to do it? And then is there compensation? He's on room air. He's on room air. All right, let me see what we got. If we got any answers. What you got, Ms. Rose? So we'll do it like this, Ms. Rose. First things first, what is pH doing? Acid. So we are in an acidosis. Next thing is to find out who's causing the problem. So let's look at the CO2. CO2 of 85 is what, Ms. Rose? Acid. Okay. A bicarb of 10 is what, Ms. Rose? Acid. Okay. And so if all three of them are acid, Ms. Rose, what is that? Mm-mm.
Oh, combined.
Combined. There you go. Combined. There you go. This is a combined acidosis with, now, Ms. Rose, a PaO2 of 36 is what? Severe hypoxemia. There it is. pH is acid. CO2 is acid. Bicarb, acid. So all three of them are acid. So that is a complete acidosis. Complete what? They don't like you to say complete, but they want you to say combined. Okay, combined. Combined acidosis with severe hypoxemia. Okay. All right. So for you guys in this situation, what's something that I could do as a respiratory therapist? Because I can't do nothing with the bicarb because I'm not a nurse. But as a respiratory therapist, what would I do to correct that?
Give more oxygen.
Yes, I could give some oxygen for the hypoxemia. What about the acid-base status? What would I do to fix the acid-base status? They have a very, very high CO2, right? So what do I need to do? I want to get it down some, but how do I do that as a respiratory therapist? CO2 is AKA what? Respiratory, AKA what's the V word? Ventilation.
Ventilation.
Good. So obviously they're not ventilating well. So how would I correct that?
Put them on a vent.
I can put them on a vent, but I'm looking to increase the ventilation, right? So I'm either going to increase their respiratory rate or their tidal volume, right? That's what you got to be ready to know that. That's how you manage this. If I'm a respiratory therapist, I know that the CO2 is ventilation, right? And so if they're at 85 CO2, they're not ventilating. So I need to crank up the rate, make them breathe faster or breathe more volume. Because the more they breathe, the lower that's going to get. Okay, if you hold your breath, your CO2 is going to start going up. So if you start ventilating, it'll go on back down, right? Remember, people who hyperventilate and pass out, when their CO2 is dropping, right? So in order to fix them, you have to ventilate less, right? Slow down their breathing or their volume or put a bag over their face. That's why they put the plastic paper bag over their face so it catches that CO2 because they're blowing it off so fast it allows them to rebreathe it and keep it from dropping too low, okay? So remember, because y'all want to see this, especially ones that are past 210, ABG management. The CO2, remember this, how to fix CO2, you're going to manipulate the respiratory rate or the tidal volume. That's how you fix the CO2, right? And in order to fix the PaO2, we're going to manipulate either the FiO2 or PEEP. That's how you fix oxygenation. So this will fix ventilation, and this fixes oxygenation. Two different things, guys. You don't fix ventilation with oxygen. If it's a ventilation problem, you need to either ventilate more or ventilate less. Okay? If it's an oxygenation problem, you give them more oxygen.
But this person had both. So what would you do in this case?
So in this case, I asked the question, as a respiratory therapist, what could I do? I would want to increase their respiratory rate or their tidal volume, and the nurse would give some bicarb. The nurse would have to inject some sodium bicarb to increase the bicarb.
So would that end up fixing their hypoxemia?
No, not the bicarb. Remember, Sydney, oxygenation and acid-base status are two different trees. Apples and oranges. You fix oxygenation with oxygen. Okay? If there's PaO2 is really, really low, you need to give them some more FiO2. You need to cut them up. If they're on 20, he's on room air, so I need to give him some oxygen, right? Get him up higher. That will fix PaO2 only. Oxygen will not fix the CO2 issue. They're two different animals, cats and dogs, okay? So in this case, we both have to work together. Respiratory would mess with the respiratory rate or the volume, right? We'd also would give them some more oxygen, and the nurse will give them a amp of bicarb, okay? That's how that will be fixed. So that's what y'all gonna be coming on to in 220 is ABG management, how to manage these ABGs. Okay, so make sure you take a picture of that so you can always remember that. Two things. CO2 is respiratory rate and tidal volume. That's it. That's how you fix ventilation. And how you fix oxygenation is FO2 or P. That's it. Okay? That's it. All right, so let's look at another one. You good? Okay. Next ABG. My purple. pH of 7.45, CO2 of 50, bicarb of 32, and a PaO2 of 60. Look at that one and work that one out. pH of 7.4. You need some paper on? You want some scratch paper? Anything? Okay. pH of 7.45, CO2 of 50, bicarb of 32, and a PaO2 of 60. Hello? What's up? Where's my parents from? Why? What you need to do that for? You need to be moving for. Well, no, you can mess with that gas. I'll look at it when I get home. You can't mess with that gas, because that causes a problem if you don't do it right. What you mean? So you already did it? Why are you asking if you already did it? No, it could have been something else that you did it before asking me. You could have ruined your whole life. But I'm trying to figure out why. Did you even do it? For what? You're not driving. But you're not going without nobody driving you, so she would have to do anything to put it in her before flight. She ain't gonna run out of gas with you. Yeah, okay. Well, I gotta go. No, we don't have to do stuff. You're not driving on your own. I hope so, because I do have some athletes in there. So like I told you, I'll talk to you about it when I got a class. I hope you don't just destroy your car. All right, so what we got here? pH is 7.45, okay? Tell me what, Lori, tell me what is pH doing? Okay, it's alkaline, but it's still in normal range, right? So you have to say normal, but leaning, right? Alkalosis. All right, pH is normal, 7.35 to 4.5. That's normal, but it's leaning alkaline, okay? So let's see who's causing the lean, right? And Lori, CO2 is 50. So what is CO2, Lori? It's acid. And bicarb of 32 is what, Lori? Alkaline. All right, so who's causing the lean, Lori? Metabolic. So if bicarb is causing the lean, it's a metabolic issue. So a metabolic. So he was the second player, and CO2 will be the third player in this case. Okay, the second player is the one that's causing the problem. All right, so this is a metabolic alkalosis, right? Now, third player is CO2. Is CO2 in normal range, Laura? No. So that means there is compensation. So we have a compensated metabolic alkalosis. All right. Now, Was CO2's compensation enough to pull pH back into normal range? Yes. So it's fully. So fully compensated metabolic alkalosis with mild. 60 is, I think 60 is mild, right?
Okay, yeah, ma'am.
So it's mild.
Yeah.
79 to what, 60? Okay.
Yeah.
So mild hypoxemia. That's it. Fully compensated metabolic alkalosis with mild hypoxemia. Okay. All right. Last one, and we're gonna move on. Last one. All right. pH of 7.1, CO2 of 10, and a bicarb of 50 with a PaO2 of 100. Work on that one, put it in the chat. All right, Charisma, are you with us?
Yeah, I'm here.
Okay. So I'm gonna let you work. I'm gonna get people put it in, but I want you to work this out for us, okay? I got a few answers. Cassie looks good. Stephanie good. Heather good. Kelsey good. Michael and good. Okay. All right. Looking at this one, Charisma. First things first, what is pH doing? So what is pH doing, Charisma?
Acid.
Okay, so we know we have an acidosis. All right. Now, let's see who's causing the problem. What is CO2, Charisma?
Alkalosis.
Alkaline. And what is bicarb?
Alkalosis.
Alkalosis. Okay. So who's causing the problem?
It's a lab error.
That's a lab error. One of them has to be going the same way as pH. Okay, so this is a lab error. Lab error. One of them has to be going the same way as pH. If that's not, it's a lab error. All right. Any questions on ABGs before we move on to the next section? Any questions on ABGs before we move on, guys? Because we're going to move on with the review. See you later. Okay. Don't have any questions. We're going to move on to pulmonary mechanics. Talk about some pulmonary mechanics. All right. Make sure you know you're able to draw your spirogram. All right. So looking at our spirogram. All right. We have Either one of them should work. All right, that's your spirograms. Make sure you know how to draw this spirogram. You must know what everything is and how to explain it to me. Must be able to tell me their values, right? All right, so we have, don't forget, you have 4 volumes and 4 capacities. 4 volumes, 4 capacities. So Kelsey, what is IRV?
Inspiratory reserve volume.
Inspiratory reserve volume, okay? Inspiratory reserve volume. How much is it?
3.6. No. Hold on, let me think.
IRV. Huh? 3.1. All right, so IRV is 3.1 liters. 3.1 liters. And it is inspiratory reserve volume. Kelsey, explain to me what inspiratory reserve volume is in words.
It is max inhale following quiet exhale.
Not quiet exhale.
Inhale?
Maximum.
Oh, yeah, that's right.
There you go. Maximum amount I can inhale after a quiet inhale, right? Tidal volume is your quiet in, quiet out. Quiet in, quiet out. Quiet in, quiet out. Quiet in, right? So tidal volume is the normal air you breathe during quiet breathing, okay? What is the normal amount for tidal volume, Michaelin?
0.5 liters.
0.5 liters, good. All right, so tidal volume is 0.5. 0.5 liters. All right, ERV. Lori, what is ERV? Expiratory reserve volume. Good. ERV is expiratory reserve volume. How much is it, Lori? 1.2 liters, right? And how would I explain ERV, Lori, in regular words? Good. The maximum air that can be pushed out following a quiet exhalation. Okay? Quiet in, quiet out, quiet in, quiet out. And then if I push far as I can go after a quiet out is my ERV, which is 1.2 liters. All right, Shatara. Shatara, what is RV?
RV is the residual volume.
Residual volume. How much is it, Shatara?
It is it the 4.8? I don't know the box.
Okay, Heather, can you tell us what the RV is?
I know it's, you talking about what the liters is?
Yeah, the liter from,
Yeah, the liter 3.6.
Heather, are you with us, Heather?
Yeah, is it 1.2?
Also 1.2, good, 1.2 liters. Okay, now, those are the 4 volumes.
I heard your teacher.
Those are the four volumes, right? All right, now we're going to deal with some capacities. Let's deal with some capacities. Now, the first capacity we're going to talk about is IC. So let me see who else is in here. Cassidy. Cassidy, what is IC?
That's your inspiratory capacity.
Okay, inspiratory capacity. Now remember, capacities are two or more volumes, right? Two or more volumes or capacities together will give us our capacity. Okay, so looking at your chart, what two volumes make up inspiratory capacity, Cassidy?
Your IRV and your VT.
Good. So IRV plus VT equal my inspiratory capacity. How much is my inspiratory capacity?
3.6 liters.
Good. 3.6 liters. All right. How would I explain that in words, Cassidy?
It's a maximum inhalation following a quiet exhalation.
Excellent. Maximum, see, it's all of this. So it's the maximum I can inhale after a quiet exhalation. So normal in, normal out. That's quiet exhalation. Then I suck in tidal volume and I keep on sucking in IRV. Both of those together is my inspiratory capacity. That is my capacity to inhale. Okay, good. All right, let's see who else is in here. Jessica. The next capacity is FRC. What is FRC, Jessica? Are you in here, Jessica?
I'll do it if you want me to.
Let me see what my fault. Let me see who all is in here. Maybe I have not seen yet. Jessica, Heather. Christian, you with us? Or Maria? I know you have volume issues, Maria. Charisma. What is FRC, Charisma?
FRC is functional residual capacity.
Good. Functional residual capacity. So that is ERV plus RV gives us our FRC, right? So how much is the FRC?
2.4 liters or 2,400 milliliters.
So 2.4 liters. Good. And if I was to explain it in words, Charisma, how would I explain FRC?
It'll be gas in the lungs following a quiet exhalation.
Good. So the gas that's left in the lungs following a quiet exhalation. So here we go again. Quiet in, quiet out. Quiet in, quiet out. If I was to stop right there, all the gas that's left in my lungs will be ERV plus RV, which is my FRC. FRC, don't forget, is the most important of the lung volumes. That's what we function with, right? FRC is directly related to what?
Compliance.
Compliance. What you say?
Compliance.
Compliance. Excellent. Compliance. And compliance is the ability for my lungs to expand. Right? How can they expand? That's how either they're stiff and have a low compliance, or they're really, really floppy with a high compliance, right? So if FRC is directly related to compliance, then my next question is FRC. What is the relationship between FRC and what's the name of the word?
Restrictive.
Oh, elasticity. What is the relationship between FRC and elasticity?
They're opposite.
Good. They are inversely related. So if I have a high FRC, then I have a low elastance, right? It doesn't snap back. Okay, so make sure y'all are able to put those analogies together, or whatever you call it, those comparisons together. So here it is. If FRC goes up, then compliance is up. Okay? If the compliance is up, then the elasticity is down. So if that's true, then if the FRC is up, then the elasticity is what?
Down.
Down. So make sure you're able to understand this concept, because this is a very important concept. Relationship between FRC, compliance, and elasticity. So make sure y'all remember that when you're thinking about different things. You have different scenarios, right? Now that you've learned some diseases, tell me what the relationship is between, let's say, pectus excavatum. What is the relationship between pectus excavatum and, let's say, compliance?
Compliance is down.
Good. So if you have pectus excavatum, they're going to have a low compliance, because pectus excavatum is what type of disease?
Restrictive.
Restrictive. Right? So this is a restrictive disease, which means it has a low compliance. What about this one? What about panlobar emphysema? Panlobar emphysema will have, what is the relation between panlobar emphysema and elasticity?
Elasticity is down.
Elasticity is down. Good. So if I have panlobar emphysema, I'm going to have a low elasticity, Lori, because the panlobar emphysema, Lori, is what type of disease? Panlobar emphysema. Emphysema, obstructive. Emphysema is a obstructive disease, which is going to have a low elasticity and a high compliance. Okay. All right, guys. Last one. Last one. Vital capacity. VC. That's vital capacity. So let me see who else is in here. Sydney. You with us?
Yes.
Okay. Sydney, our vital capacity, which is VC, how would I explain vital capacity in words?
Is it everything that the lung can hold?
And everything that the lung,
Like all the reserve volume and everything.
Oh, vital capacity is not everything the lung can hold. What is vital? What is vital capacity? You're looking at this right here. What is vital capacity?
The tidal volume, and then the expiratory reserve volume and expiratory reserve volume.
Okay, you can say that. Vital capacity is IRV plus VT plus ERV. Good. That's one way. Somebody give me another way to explain vital capacity.
A maximum exhalation following a maximum.
There you go. A maximum inhalation following a maximum exhalation, right? Everything that you can do. Everything that you can do. All the air you can suck in and all the air you can push out is your vital capacity. But even if we push everything out, Shatara, what's always left, Shatara? Shatara, you there?
Yes, sir. I'm here.
Okay. So after everything has been pushed out of your lungs, what's left? After I push everything out of my lungs, what is left?
Is it oxygen?
After I push everything out of my lungs. So if I exhale and push far as I can push, which is my vital capacity, what's left that I can't access? Anybody?
Residual volume.
Residual volume.
Reserve volume.
Reserve, yeah, residual reserve, same thing. After I push everything out, I still have a little bit of left in my lungs called RV, which is residual volume. Now, vital capacity, who knows how much is the vital capacity?
4.8 liters.
4.8 liters. 4.8 liters
4.8.
is my vital capacity, okay? Now, the last thing, what somebody have, what Sydney, what you had thought earlier, everything that's in the lungs right now, every bit of it is my total lung capacity. And the total lung capacity is how much?
6 liters.
6.0 liters. That is pulmonary mechanics. Talking about FRC, compliance, elasticity. Now that you've learned some diseases, like the CBABE diseases will all have high FRCs and high compliances, right? And all of your restrictive diseases will have a decrease in compliance, right? Because they can't get the air in because of whatever reason, whether it's a skeletal issue, whether it's a pulmonary edema, you know, all of those restrictive diseases, tetanus, all of that stuff. You need to make sure you know that. That's how you can relate. So you're always looking at the patient's history, right, to find out what to expect. If you know that the child has cystic fibrosis, then you're going to expect a certain type of pulmonary function, right? Pulmonary function. If somebody comes in with COPD, or let's say they come in with emphysema, you know Mr. Johnson has emphysema, then you already know he's going to have a high FRC. He's going to be a CO2 retainer, right? You're going to expect to see high CO2s. You're going to expect to see low oxygen levels, right? You're going to expect to see a high compliance, and you're going to expect to see a high FRC. That's already in your mind as soon as you read that he has COPD, okay? Or emphysema, or whatever that CBABE diseases are, you're already gonna know right off the top as a therapist what to expect. And then you start thinking about how am I going to treat, right? This right here is considered the gold standard, right? A well thought out, performed early PFT. Now this is just part of it. A real PFT, the patient will be sitting in a body box with a computer hooked up to the mouthpiece, reading all of these different functions. We get that first, and then we know where we are. Do we have a restrictive patient? Do we have a obstructive patient? And where do we need to start in our therapy? Okay, very important. All right, so we're going to take a break. Let's take a 10-minute break, and we're going to come back. I'm going to go to RT210A and kind of skim through some of that, answer a couple of questions, and then I'm going on to the cardiac anatomy, which is the blood flow through the heart and all of that. Okay, again, those lessons are already loaded in this module, so you can go back and look at. When you go back and look at those pre-recorded lectures, disregard the dates, and then when I tell y'all come in here for CPR, all that was then. Okay, just focus on the material from the review. All right, let's take a break. We'll come back at, so my watch is a little different than, yeah,
It's
so
1:46.
so let's just say 1:45. Come back at 55 after. Come back at 1:55 and we're going to continue on. All right, guys, back from break. Let's go ahead and get started on a few things. Like I said, I don't want to completely copy everything that's already in your module, right? The module already has a good review, step by step, module by module. So what I'm going to do is go and pull up some questions from each module, some of those alternate exam from each module, and just pull up a few of those, maybe 10 or so from each one, and work our way down, okay? All right, so let me pull up RT210A. Now, when I call your name, you just tell me what you got for this one. For that, I'm gonna put them on the screen. They're not actual test questions, so you know. But another thing is, try your best to answer them. Try your best to answer them without looking, because we're at this point now. You're about to have your final. If you still have to look up answers for everything, then you're not ready. Okay, it's not a grade today, but it's a grade for yourself. Okay, this is one of these things that you're grading yourself. How much do I know? How much have I put into this? This is where the rubber meets the road, guys. You're at the end. I know we've all had struggles and hardships, sicknesses, and power problems, corona. You know, it's a lot of things. That's just showing your strength and your resolve. You can go back and tell your kids or your family members and remember how you went, what you went through for 2020, right? And how you still stayed true to yourself, and you kept on working hard, and you beat it. So when you get your degree and you start working, making those good money, then you can always go back and say, you know what, I remember when I was in school, I almost quit because there was so much going on, but I held in there, sickness and all the other stuff, but I still made it. Okay, so you need to see how much have you attained or retained without looking. Okay, so let me pull it up. Get my flash drive. Come on now. All right, here it is. All right, so get your mind ready for RT210A. RT210A, try to get this without looking at your notes. I'm not going to really give a lot of time. I'm just going to go on. All right, here we go. Share my screen. All right, we'll start off like this. Let's start off around number 7. Everybody look at 7 and 8. 7 and 8, and then I'm gonna call somebody to answer these two, and we're going on. Okay, Stephanie. If you want, you can cut your camera on so I'll know who's ready to answer, who's not. I got one student that can't talk right now, so that'd be better if everybody's on. So whoever's not on, I know you can't talk. All right, number 7. Which of the following list of priorities of therapy in respiratory care in the correct order? In the correct order. So, Lori, which one did you pick for 7? You picked A. Okay. A is incorrect. Cassidy, what you get?
I got E.
E. E will be correct. I always remember CPR is first. CPR is first. If CPR is going on, that's the first thing you do. So CPR, then CMV, which is the ventilator, ICU, ER, and then post-op care, oxygen, right? Somebody needs some humidity, treatment, something like that. CPR is first, okay? CPR is always first. And then the vent, ICU, ER, thus and so forth. All right. Sydney, number 8. Who's responsible for the clinical functions and the medical policy of the RT department?
Is it the director? E.
E, the medical director. Medical director will be a medical doctor that's responsible for all the clinical stuff in the RT department. Good. All right. For example, Dr. Armando Fier is the medical director for respiratory at Concord. Okay. Dr. Armando Fier. He's the medical director, pulmonologist. I think he works at the Med. He works at the Med and the VA. Okay. And he's also the medical director of respiratory here at Concord. All right, number 10. And so do 10, 11, and 12. Everybody do 10, 11, and 12. Let me see something. 12 got, okay, just 3 answers for 12. Okay. 10, 11, and 12. My bad. Okay, you don't have to put anything in the chat, guys. Just only if I call you. If I call you and you can't talk, we can put it in chat. But until then, just look at it. If I call your name, answer, but don't have to put everything in the chat. 10, 11, and 12. All right, so let me look and see who I got. Jessica, are you, Miss McIntosh, are you with us? All right, let's see here. Courtney, I have your pulse ox probe in my bag.
Can I get it Thursday?
Whenever you come, it's fine. It's in my bag. All right, so Courtney, number 10, the term febrile means what?
A, fever.
Fever. Somebody is febrile, they are considered to have a fever. All right, Michaelin, speaking of that febrile, at what point Celsius are they febrile?
100.1.
But I mean on Celsius.
Oh, so
That'll be like 39 Celsius,
Just
38-ish, 38,
anything over what, Michaelin?
37.
37. Oh, that was for Michaelin. All right, number 11. All right, number 11. Kelsey, bronchoscopy is what, Kelsey?
Visual exam of airways.
Visual examination. Take a look. It's almost like a video game. Take the scope and go down either the trachea, right? We either go down their trachea here with a scope or in their ET tube. And if they're not intubated, we can go down the nose and go down into the airway and just do a visual. You have a little thumb where it moves the edge, where it turns it where you want to go. We can look at all the segments. We can go to apical segments. We can look at the lingula. We can look at all the parts of the lung to see if there's something there. It could be some type of tumor. It could be some type of just some thick secretions, right? We can go in and we can scrub off the side. If we want to get a little cyto brush, and we can stick the brush in the scope, and then it will stick through, and you can scrub a little piece of sample, send it to the lab. We can pinch off a piece of tumor or skin or whatever, to test it. So bronchoscopy would be visual examination. Number 12, tracheotomy. A tracheotomy, Charisma, is what?
A incision into the trachea.
Incision. Tracheotomy will be the incision, okay? All right, 13, 14, and 15. 13, 14, and 15. All right, Cassidy, number 13, retrosternal space. Where is that space at, Cassidy?
Is it D?
Behind the sternum. Good, behind the sternum. All right, Shatara, tachypnea. When somebody's experiencing tachypnea, what does that mean, Shatara?
Is it rapid? I want to say rapid heart rate.
No, that's tachycardia. Tachypnea.
Okay, so rapid respiration.
There you go. Rapid respiration, tachypnic. When somebody's tachypnic, they're breathing fast. And hypertrophy. Hypertrophy, Maria, if you can put it in the chat for us, Maria. What does hypertrophy mean? She might have stepped away. Sydney, hypertrophy. What's hypertrophy mean, Sydney? Number 15.
Is it only A through D?
Huh?
Okay. C, underdeveloped.
Underdeveloped? No, that will be incorrect. Atrophy is underdeveloped.
Oh, sorry. A, increase in size.
Increase in size. Sometimes the heart has hypertrophy, where it's overly developed because it's working so hard, it gets bigger and bigger. If it's having a problem pumping blood, it's going to get bigger and bigger, just like any other muscle that you work. All right. Now, going on to RT210B. Are there any questions on A? That you guys have any questions on A? Pretty much just that. See, there's your Fahrenheit, Celsius stuff. Just your terminology, different things about ethics, right? Remember we talk about ethics. You have two types of law, torts and something else. I forgot. You have to look it up. But assault, you need to know the difference between assault, negligence, battery, and slander. Right. Courtney, you got a question?
Yes, sir. On the study guide, it asks what tests are considered diagnostic.
Yeah, so things that like a X-ray, right? Anything that you can do a test to diagnose something. So an ABG, we could diagnose something with ABG. We can do an X-ray. An X-ray will help us diagnose, right? An MRI, CT, all those type of tests will allow us to diagnose something. Any other questions on 210A? All right, let's move right on along. All right, so let's go on to 210B, cardiac anatomy. Cardiac anatomy. Cardiac anatomy. All right, let me share my screen. All right, starting back with Lori. Lori, look at number 2. What term is used to describe a red blood cell count above normal? Red blood cells above normal. Which one of those terms is that? Lori? C, anemia? No. Anybody else?
Would
Polythemia.
be A.
Polycythemia.
A, leukocytosis. No, I'm sorry. D, polycythemia. Polycythemia. That is a high red blood count. High red blood count, polycythemia, right? And what patient do we might see this on? Which type of respiratory patient might you see an elevated red blood cell count? We just talked about that the other day. Anybody?
Which one we on? I'm sorry.
Still on number 2, I'm asking the polycythemia, what respiratory patient might we see polycythemia on or in?
Isn't it someone who has a restrictive disease?
Was it restrictive or obstructive?
I think it was restrictive, but I don't know 100%.
I think it's obstructive to your COPD patients. I think it's your COPD patients. You will see, and it's like, it's like, why do they have that? I really don't know myself, but I do believe that your COPD patients may exhibit polycythemia. Okay, so make sure you answer that or add that to your list when they have COPD patients may have all of these except or whatever, right? Polycythemia is something that they have, okay? Let's look at number 3, Sydney. Most of the muscle mass of the heart is located in which chamber?
I know I got this one wrong on the test. I don't know. Is it the left ventricle?
Left ventricle. It's the left ventricle because the left ventricle is the one that pumps the blood to the body. The left ventricle is the one that has the most muscle mass because it has to squeeze the blood all the way through the whole systemic system, which is to the body. Okay. The right ventricle doesn't have to pump real far. It just has to go to the lungs right next door. Okay. All right. Heather, you with us, Heather?
Yeah, I'm here.
Okay. Atrial flutter, number 4. Atrial flutter is considered to be a life-threatening arrhythmia. Is that true or false?
False.
False. Atrial rhythms are not life-threatening. Okay. All right. Let's see here. Michaelin, number 5. Number 5, Michaelin. Which of the following represent the correct order of the structures encountered by the blood flowing from the vena cava to the aorta?
D.
D as in dog?
Yep, D is in dog.
So after the superior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary valve, pulmonary artery, pulmonary within the lungs and the pulmonary veins, left atria, mitral valve, left ventricle, aortic valve. Excellent. Excellent. Number 6, Courtney. Which of the following electrolytes is not commonly measured? Which one of these is not commonly measured?
D. Chloride.
Chloride, I'm not sure. Let me check. This is that PNR. What number was that? Number 6. Let's see. Magnesium. Magnesium is not oftenly measured. Magnesium. Sodium is very important, potassium and the chloride, but magnesium is important, but it's not usually measured, okay? All right, number 7, Cassidy. What type of white blood cell increases in response to allergic reactions? Which white blood cell, remember the leukocytes, which one of the leukocytes will increase if there's an allergic reaction or allergen in the body?
B.
B, eosinophils. Good, eosinophils. All right, let me go down a little bit more. Number 16. Kelsey, number 16. Your patient has an EKG, a normal EKG reading. What does this finding tell you about their likelihood of having an MI, which is a heart attack, in the immediate future?
Less than 10%.
Okay, no, that answer is D, no predictive value. Remember, EKGs cannot predict. They can only tell you what's happening right now or what happened in the past, right? EKG can tell you what's going on right now or what may have happened in the past, but it cannot ever predict. It has no predictive value. Okay, you can't say, well, looking at this, you're probably gonna have a heart attack in the next 10 years, right? It's no predictive value at all. All right, let's see here. Oh, 18. Let's see who I got it. Yeah. Charisma, number 18. Which of the following represents a normal serum potassium? Potassium. Pick the best one. Might not be the exact numbers you're used to, but pick the closest one to what you know. Potassium.
B.
Oh. That one would be more close to what? B would be more close to what? What electrolyte would B be? Anybody?
Chloride.
Chloride. 96 to 1024 or something like that. Chloride. But potassium is what? D? 3.5. Yeah. So 3.5 to 5. Remember, you get about 3.5 to 5 bananas in a bunch, right? Potassium is D. All right. Now, remember, when you take these answers, guys, on your final or your board exam, whatever, it might not be the exact numbers you learn, but you pick the best one, okay? 137 to 147 is not what we learned for what was that, sodium? I'm not sure by my own head, but I know it's close. If that answer was that, then I would choose that, okay? So 3.5 to 4.8, that's not exactly what you learned, but that's the closest one. All right. All right, let's look at a couple more. We're going on to the next lesson. Number 19, Stephanie, I know you're listening. If you can put in the chat if you're able. What test is useful for determining the blood clotting ability of your patient? Stephanie, if you can put it in the chat, I'll give you a moment. If not, we'll ask someone else. What tests do we use for determining the blood clotting ability? Trying to see if your blood is able to clot well. All right, let's see what she said. Good, Stephanie. B, platelet count. We're going to count your platelets, right? Platelets are what makes you stop bleeding. They clot the blood up so that you don't bleed to death from a paper cut. You know, you can bleed to death from a paper cut over time if you don't have any platelets. It's going to all run out, okay? All right, let me go on. A couple more. 20, 21, and 22. We're going to do these three, and then we're moving on to pulmonary A&P. (20, 21, and 22). Courtney, you will do 20. Lori, 21. And Michael, and you'll do 22. I mean, you can do them all, but, you know, focus on the ones I will be calling you for that. I know y'all laughing at my glasses. I ain't never seen me where I hate wearing them. I needed them today.
Better wear them, you'll be like me.
All right, number 20. Who did I say? Courtney?
Yes, sir.
And number 20, what condition is often associated with right axis deviation?
Is it A, cor pulmonale?
Cor pulmonale. See, they said right axis deviation, but you know, it's either right side heart failure, all of that's on the right side. We know cor pulmonale is stuff that's on the right side, right? If it was left axis deviation, would probably be CHF, right? Or mitral valve, could be mitral valve, you know, or D, right? So they said right, everything else is left. When you look at the choices, everything else on there is a left-sided issue, okay? 21, on inspection of an EKG, you notice the following regular sawtooth wave. You can stop right there. Sawtooth pattern, Lori, is what? No, not VTAC. What did I say the cutter was? Sawtooth is cutter for flutter. Flutter the cutter. Flutter the cutter, like a knife. Okay? And then 22, Michael, which of the following waves represents repolarization of the ventricles?
C, T. It's the T
T
wave.
wave. The T wave.
What?
Question?
Is there a U? I don't remember you saying a U.
Yes, there is a U, but you can't see it. The U is the repolarization of the atria, but the
Okay.
QRS is so big, you can't see it.
Okay.
Okay, so that may be a question. What is the U wave? The U wave is the repolarization of the atria, right? Because the atria contracts and it also has to repolarize, right? The ventricle contracts and it has to repolarize. But since the ventricle's contraction is so big, you can't see the U. So you can't see the repolarization of the atria because the QRS is so big it blocks it. Okay, so that's why. That's what the U is. All right. What is this right here? We'll do this one. Everybody look at 27 and then you tell me what you think and we'll go from there. 27 and 28. And 28 will be a process of elimination. You really got to look at process of elimination, knowing what you know to make an educated guess to get that one right. Because every point counts in the final. 100 questions, 1 point apiece. All right, 27 says the semilunar, which are pulmonary and aortic valves, they're just semilunar valves, do which one of the following? What do they do? First check said they separate the ventricles from their arterial outflow tracts. They prevent arterial backflow through the ventricular relaxation during ventricular relaxation, and consist of 3 half-moon crescent-shaped cusps. What do the semilunar valves do? Which are the pulmonary valve and the aortic valve. So think about the question. The semilunar pulmonary valve and aortic valve, what does it do? 27. Anybody got an answer?
D?
Said B as in
C.
boy,
No, D as in dog.
B as in dog. Okay. Our choice would have been B as in boy, just 2 only. But I'm gonna check because I could be wrong on that one. This is from the P&R, so those are a little bit harder. But yeah, consists of 3 half moon crescent shaped cusps. I think that's the bicuspid and tricuspid valves. I'm not sure. I know that I would think that it prevents arterial backflow during ventricular relaxation because this is the pulmonary and aortic valves which lead to their arteries, pulmonary artery and aortic artery. So definitely I think that it will prevent the backflow. That valve keeps the flow from going one way backwards, right? If it's supposed to go from the right ventricle into the pulmonary artery, then I don't want it to go from the pulmonary artery back into the right ventricle. So it prevents that backflow, right? That valve prevents the backflow. And so since 2 is in all of them, it's hard to eliminate that. So let's see what they say 27 is. 27 is C. So who said C for 27? Nobody said C. Let me see
I
what.
did.
Okay.
I said C.
Okay, good. So separate the ventricles from their arterial outflows. Okay. All 3 of them. I thought this right here would have been the bicuspid valves. But okay, so all of them consist of 3 half moon or crescent shaped cusps that prevent the arterial backflow during ventricular relaxation and separate the ventricles from their arterial outflow tracts. Interesting, right? Interesting. Learn something every day. And then 28. What are the main intracellular electrolytes? So on this one, there's one that you should be able to get rid of immediately. Cassidy, which one of those can I get rid of, knowing what you know?
C.
Huh? Oh, you give me the answer?
No, I was saying you can get rid of C.
Oh,
Or
okay.
the
No,
C.
no,
Oh,
no,
you
no.
mean
The actual electrolyte. Yeah, which one of the electrolytes can we get rid of?
4, Na.
Sodium, right?
Yeah.
Because sodium is on the outside of the cell, and which one is on the inside of the cell? When we talk about depolarization.
It's potassium.
Potassium. So since we know that the cell is rich with potassium and the outside of the cell is full of sodium, sodium comes in, causes the depolarization, right? So knowing that I can get rid of sodium, which ones can I get rid of? Which choices can I get rid of?
A, B, and C.
All right, so you're left with D. Okay, phosphates, potassium, and sulfate. Okay, get rid of sodium because sodium is hanging out there on the outside. Okay, that's the kind of stuff you have to do, guys. When you're not sure and they test, some of them are kind of hard. You gotta use process elimination as much as you can. Okay, pulmonary A and P. Pulmonary A and P. Let me make sure you're seeing my screen. All right, here we go. Let's look at 5 and 6. 5 and 6. And Sydney, did you get that question that you wanted answered? Did I answer that question about the cardiac?
I haven't heard it yet, but
What did you ask? After this, I will answer it right quick. What did you ask me about? Did you say the electrical flow?
no, I know the electrical flow, the blood flow.
Okay. So after 5 and 6, we'll talk about the blood flow. Okay. All right, number 5. Let me see. Let me go to the other side over here. All right, Shatara. Can you hear me, Shatara? I think she might be gone. Yeah, she gone. Maria, are you with us, Maria? Okay. Maria, number 5, normal diaphragmatic excursion during resting ventilation, right? Just normal breathing. What is the excursion? That means how much does it move, or how much does it bend? Come on. All right, Maria, A, 1.5 centimeters. Good. 1.5 centimeters. Number 6, which of the following is true of surfactant? Lori, what all is true of surfactant? The choices are, it is a phospholipid. The next one says it decreases surface tension. The next thing it says it causes alveolar collapse. And the last one is continuously produced and eliminated. All right, so which one is your choice? D. It is a phospholipid. It decreases surface tension, and it's continuously produced and eliminated. It does not cause you to collapse. It causes it to not collapse. All right, we give it to keep it from collapsing. Excellent. All right, Sydney, blood flow through the heart. Deoxygenated blood returns to the heart. Here we go right here. Let me show it right quick. All right. Deoxygenated blood returns to the heart via the superior and the inferior vena cava, right? It dumps into the right atrium, right? From here down into the right atrium. It goes through the tricuspid valve, right? So that's the tricuspid valve into the right ventricle. Then it goes through the pulmonary valve into the pulmonary artery. After the pulmonary artery, it goes into the lungs. Okay? It picks up oxygen and releases what? CO2. Okay? Now, blood-rich or a fully oxygenated blood now returns to the heart from the lungs via the pulmonary veins, 2 sets from both lungs, right? Pulmonary veins, and they dump into the left atrium, right? In the left atrium. After the left atrium, it goes down through the bicuspid valve or mitral valve, right? Into the left ventricle. When it leaves the left ventricle, it shoots up through that aortic valve, through the aortic valve into the aorta, right? And from the aorta to the body, right? Goes down and goes up. These carotids here go up to the brain, and then you have the bottom one part of the aorta will go down your middle of your body and separate down into the body, the legs, arms, all of that, okay? That is the blood flow of the heart, or through the heart, okay? Don't forget the heart has to get its own blood and get rid of its own CO2 and stuff, right? So the blood, the heart is supplied blood by what? What is the name of the artery that takes blood to the heart itself, right? It goes away from the heart, but then it comes right back, right? It supplies the heart its blood. What's the name of that artery that supplies the blood to the heart? It's right here. This red artery right here is what gives the muscle its blood, right? What's the name of this red vessel here, this artery? Right? If one of these becomes blocked, there's an ischemic situation. The tissue starts to die, and that's what causes a heart attack, because it had lack of blood to that area. So it was ischemia, started to become necrosis or necrotic, and then it got weak and let you know it with a heart attack, okay? And then it has a vessel that takes the deoxygenated blood away from the actual heart muscle back into circulation to get reoxygenated. So what is the name, Courtney? What's the name of this red artery here? that gives the nutrients to the heart?
Is it the carotid artery?
No, that's this is the carotid arteries up here. Close though. Sounds like that.
I'm not sure.
Okay. Anybody else? Michaelin, what's this artery right here? What is this?
I'm not sure off the top of my head.
It's
All right.
pulmonary veins.
Not the pulmonary veins. This is an artery here. This is the coronary artery, coronary vein. Remember that? Coronary artery and the coronary vein is what supplies the heart with its rich oxygen blood and removes the stuff, the deoxygenate back into circulation. Okay, it's got to have its blood too. So the heart is responsible for giving blood all through the body, right? But who's giving the heart its blood? It's a muscle too. It's got to have blood too. It's got to have nutrients. It's got to have respiratory gases, right? Same thing that the blood does for the body. And that is through the coronary artery and the coronary vein. Remember we talked about ischemia or heart attack. We said if the coronary artery becomes blocked with your chitlins, remember I said that? If you eating chitlins and fried chicken and all that fat blocks your coronary artery, right? It becomes ischemia, lack of blood flow to this muscle. Look, this muscle of the heart said, where my blood at, right? Well, it's blocked because of the blockage, either atherosclerosis. Remember fat deposits in the artery is atherosclerosis, right? So if we have atherosclerosis in the artery, it will block the blood from getting to this muscle. If it's blocked, guess what? It's going to die, and it's going to let you know that it died, okay? And so we have to go in and put a stent. You've heard of a stent? They go in and put a little screen in and open it up. If they can't open it up, they can bypass that, right? A bypass surgery is when they make another vessel from your body and stick it from here and skip the blockage back to the heart, okay? So either a bypass surgery or a stent be placed, okay? So don't forget about those two. They need attention as well. All right, moving right along.
This might be a stupid question, but so is the aorta an artery?
The aorta is a very large artery.
Okay.
Yeah. Aorta, because it takes blood away from the heart, right? But don't get confused with the coronary artery because it's going away from the heart, it's per se, but it's looping back around to give the heart its blood. All right, let's look at a couple more. Let's look at 8 and 9. 8 and 9. We'll go with, give you a moment to look at it. All right, charisma, number 8. Which of the following are or is or are an accessory muscle? Which one of these are considered accessory muscles?
I'm gonna say C.
C, 2, 3, and 4. Good. 2, 3, and 4. Your scalene, your sternocleidomastoid, and your pectoralis, the pecs, right? Those are because the diaphragm is not a accessory muscle. That's the main muscle, right? And the teres or teres major, I don't even know what that is. All right. Number 9, the diaphragm is innervated. That means stimulated, right? Let me see. Michaelin, by the what? The diaphragm is stimulated by the what nerve?
The phrenic nerve.
Phrenic nerve. Good. The phrenic nerve. All right. Jessica, are you with us yet? Let's see here. Heather, number 10. Number 10, Heather. Which of the following muscle groups are used for forced exhalation? Forced exhalation. Are you with us, Heather?
Yeah. Yeah, I'm sorry. I was just reading it.
Okay. Forced exhalation.
Is it A?
All right, she said A, which is 1 and 2. Good, 1 and 2. You can get rid of the internal, well, I guess you couldn't. Let me see. Pectoralis is an accessory muscle. Your internal intercostals help with expiration, right? But they're not for forced exhalation. So you're going to say the abdominal muscles. That's how you blow out the birthday cake, right? You use your abdominal muscles to blow out the birthday cake candles, okay? And your diaphragm. They both work together to blow it out. So those are the two. A couple more, we're going to move on to the next lesson.
What about not for force? There was a question on a homework. If it's just regular, is it passive or what if it's
Exhalation,
not?
yes. Exhalation is
Okay.
passive. You just inhale and then let go. Unless you have COPD. If you just let go, ain't nothing gonna happen. You gotta kind of push it out because it's hard for them to get it out, right? So, but for everybody else, exhalation is passive. Okay. All right. Number 17, Stephanie, if you can put it in the chat. Stephanie, which of the following does not affect ciliary action? Remember, there are a few things that affect the cilia. One of these is not. One of these does not. Stephanie, put that in the chat if you can. All right, here we go. Stephanie said D, which is swallowing. Excellent. Swallowing has nothing to do with your cilia. Everything else, a decreased soul, those are the 4 things: decreased soul layer, dehydration, cigarette smoking, and thick tenacious secretions. Those are the 4 things that affect your cilia, right? And mainly that smoking, because when you smoke, they paralyze. All right. Kelsey, number 19. Number 19, the left lung has how many segments, Kelsey?
I think it's 10.
10? Okay, I forgot because I never
Wait.
did memorize them.
10 or 12.
All right. Michael, what you got?
I got 10.
10? Okay, let me see right quick. What number is that? 19? 19 is A, 8. The left lung has 8 segments.
Yeah, I think the right got 10.
I think so, something like that. Okay. All right, last one, Charisma. What is the difference between, or what is between the parietal and the visceral pleural? Between those two pleural, you have your parietal.
I'm gonna say E.
E, a small amount of pleural fluid. And Cassidy, what's another word for that pleural fluid? It might be, because it might be stated as this. Can you remember what that name of that pleural fluid is? Cassidy?
I'm not sure.
Okay. Lori? Not surfactant.
Cirrus.
Serous fluid. S-E-R-O-U-S. Serous fluid. So it might say serous on your test. So just be aware of that. Okay. Good job. Go through a couple more. We can take another break. All right. Let's look at a couple from pulmonary. Well, we just did pulmonary mechanics on the board. Did ABGs. Let's look at gas physics. Gas physics. All right, let me share my screen. Gas physics. All right, let's look at Courtney. Courtney, number 10. How long will an E cylinder last if it has 1,000 PSI running at 2 liters per minute?
Let me get my calculator.
Okay, no problem. While she's getting the calculator, Michaelin, number 11. Which of the following is true of the DISS? It's okay, Heather.
D.
B as in boy.
DISS. No, I said. Sorry, someone was calling.
All right.
DISS. No, I said D as in dog.
Oh, okay, good. It uses quick connections and the threaded connections, all that stuff after the regulator. Okay, don't matter if it's a big tank or a little tank, right? And they're usually not over 50 psi. All right.
140, divide that by 60 equals 2.
Wait a minute, number 10 is
Hunter!
number 10 is for Courtney. That's all right. Mr. Smith is gone to this casino. He got 1,000 PSI left in his system, in his tank, on 2 liters. How long before he need to get home, Courtney?
D, about an hour.
About an hour. Does everybody else get that? Okay, let me look and see what they say, because I don't have my, well, I got a calculator. Let me try not to show the answer.
Never mind. It's C.
I got
Around
2 hours.
About
Yeah,
2 hours? Oh, okay.
Yeah, 2 hours.
Everybody cool with that? All right, so about 2 hours. And she did 1,000 times 0.28, right? Divided by 2 liters per minute. Convert that into hours. Good. Any questions on the cylinder factors or the cylinder flow by anybody? Anybody got any questions on how long the cylinder will last? All right, what about this? What if they have a liquid at 25 pounds? How long will that last? Liquid O2 at 25 pounds. How long will that last? And it's still running at 2 liters per minute. Running at 2 liters per minute. He has 25 pounds of liquid left. Running at 2 liters per minute. How long does he have now? Tell me your answer in days. How many days does he have to sit up at the casino?
Want us to put in the chat?
Yeah, you can put it in the chat. Woo, Heather. That's a little long. Good charisma. I can't hear you, Michael. Michael, were you talking to me? Because I couldn't hear you.
Oh, I sent it in the chat.
Oh, okay. Yeah, there you go. Good. Good charisma, good Michaelin. About another minute, I'm going to tell you. Thank you. Thank you. All right, guys, if it's liquid, then the formula is 344 times the pounds divided by the liter flow. So 344 times pounds. This person has 25 pounds, right? 25 pounds of liquid. So that's 25 times 344 equals 8,600. Divided that by the liter flow, which is 2 liters per minute. And that gave us, 344 times 25 is 8,600 divided by 2 is 4,300, okay, minutes. So then we divide that by 60 to get the hours, and that is 71.6 hours. So then we divide it again by 24 to get the days. Divided by 24, and that's about 2.9, so almost 3. So we can just say you got about 2.5 days, right? If you told me you got about 2.5 days, that's fine. 2.5 days, okay? So that's how you do that for liquid. That's all right, Heather. Yeah, Heather put 179 days, but she know what she did wrong. All right. I was like, wow, that's some real good oxygen now. All right. Let's look at here. Okay, number 16. Number 16. Maria, 16. Liquid oxygen. What's true? Which one of these is true of liquid oxygen? All right, Maria said A. Has a critical temperature of 118 degrees Celsius? No. All right, let me look at the chat again. Good, it's B. Good, Stephanie. Good, Stephanie. It's B. Has a critical temperature of negative 181 Fahrenheit and negative 118 Celsius. At 118 should have been negative, right? Negative. All right, and not combustible, but it does support combustion. Okay. All right. All right, one more. Charisma. What happens, number 9, what happens with rapid decompression? Rapid decompression of a gas results in what, Charisma? That gas comes out of that tank real fast. What happens? Which one of those choices is correct?
B.
Sudden drop in temperature. Sudden drop in temperature. I think you said B. I told y'all, make sure y'all say just read me.
Yeah, B as in boy.
And they sound the same over through here. A sudden drop in temperature. So just like that can of spray, when you spray your keyboard, you spray it gets cold in your hand. If I take that cracking and I just leave it on, if I turn that H tank on full blast, that the nozzle will eventually start to frost because it's getting so cold. Okay, that is pulmonary. No, this is gas physics. Any questions on the gas physics module? It's talking about Charles, Gay-Lussac, Avogadro the mole, right? Compensated Thorpe tubes, uncompensated, stuff like that.
Hey, question 12. It says a back pressure compensated Thorpe tube.
Yes. So if it's compensated. So if the Thorpe tube is compensated, which one of these is true?
I want to say C.
The needle valve is distal to the float. They just said it a little bit different. Remember, the needle valve is distal to the float. That means it's after the float. And a compensated Thorpe tube, the needle valve is distal to the float. And that's all they're saying. It has a restriction or needle valve downstream, right? Distal, away, after the float. So the back pressure won't affect the flow. Okay? All right. Well, any other questions on gas cylinders? Don't forget, who's responsible for transportation of that and all that. Remember, the DOT is responsible for the transportation and manufacturing of all gaseous cylinders. Don't forget your colors, your other safety systems, stuff like that. That is all in that lesson. All right, let's take a break. It's 3 o'clock. Come back at 3:10. Come back at 3:10, and we're going to go on to the next section, and we're going to stop for the day. Also, don't forget, I emailed everybody that you need to be here on Monday. Be here on Monday, and I gave you those times. Be here so that we can do the CPR checkoff, and you can see your nurse, see your shot nurse on Monday. All right. Please make arrangements. If you used to coming at 4, please make arrangements with your job or whoever so you can be here by at least 3 because they leave at 4. Okay. And it might be the last time you get to see them before you go into clinicals. You cannot go to clinicals without the shots and without being signed off on the shot nurses. Okay. So your class may be able to go right into clinicals. So if you're don't have your shots, you can't go. Okay. I'm not sure. They'll tell you all of that when you get there. You don't have to have the COVID vaccine. You don't have to have it. And I don't know about I know you have to have the flu shot to go into the hospital. Okay, like at least the med. And I think that's all the hospital. They will not let you work. You used to could just put a mask on and all of that during flu season, but now not anymore. They making you have that flu shot. If you don't have a flu shot, you can't go into the hospital. So, and that's where everybody's going, to the hospital. So if you got beliefs on all that, you're in the wrong field. All right. So be here on Monday. Monday. Alpha coming right at what I tell you? Did I say 9 or did I say 1?
You said alpha at 1, omega at 3.
Yeah, 1 and then omega coming 3. That way we can knock all that out. CPR is open for everybody. If you haven't completed your 3 BLSs, go on and complete them and take the test. If you fail the test or you don't get an 84, if you don't get an 84, you failed it. I will have to open up exam B for you, but I can't just because you want a higher score. Say you get a 90, I want to do B so I can get a, you can't do that. I can only open up B if you don't score the necessary 84 on A. Okay, so if you score 86, that's your grade. Okay, it's open book. Look at the videos. All those answers come right from the video. You have to take your time. Make sure you go over the videos. Those little quiz questions with the video, they do not count toward the grade. They're just trying to make sure that you're keeping up with the video and you're not just watching the video or flashing through the video just so you can get to the test. Because all those skills that you learn on the video, you got to show us on Monday. Okay, you're going to have to show me. So if you just scattered through there and answer the questions and then you get here on Monday, don't know where to put your hands or none of that, you will not be checked off and you fail 210 because it's pass or fail. Okay, so make sure you do what you're supposed to do. You're at the end. So it's open for everybody. Just go on and look at them, do them, and then take the test. So I can go on and throw that into your grade. Okay. And then, like I say, I'll talk about I've already talked about the makeup days for lab, them 2 days, I think it was 2 or 3 days I gave you already to told you those important dates. Make sure you watch that important dates video. I put the video in the announcement, right? I put the video in the announcement, the email, it's in there. So go to your announcement, look at the important dates video. I just put at the bottom, add to that Monday, okay? All right, go ahead and take your break. At 10 after 3, we're going to come on into the last part for the day, which will be, let me see, what's after gas physics? Medical gas therapy, which are your high and low flow oxygen systems. Tomorrow, we will talk about humidity aerosol therapy, pharmacology, and we'll talk about lung inflation, okay, which is the restrictive and all that. So we'll do those 3 tomorrow. Take your break. See you back at 3:10. All right, final one for today. We're going to do a few, and we're going to get on out of here. Medical gas therapy sample questions for review, and then I ask that you ask me any questions. Today, the students in 220 were doing practicum, where they were over there setting up this stuff that you learned in 210. Now, this is going to be one that we haven't done as far as the lab, but we're going to have to do it during those 2 makeup sessions. So make sure you're looking at the video and the for the medical gas therapy, because I show the different devices and all. There should be no reason why you don't know that when we get there. If you watch it, especially, keep watching it now and studying it, you'll know what the nasal cannula is, the simple face mask, the partial rebreather, non-rebreather, the nasal catheter, then the aerosol this and the aerosol that, the Venturi setups, and what the principle of air entrainment is, the magic box, patient's demand, all of that is in this unit, which you will have probably several questions on the final about this, okay? So make sure that you go back and study this really well. Number 1, Cassidy, are you back? Is
Yeah, I'm
everybody
back.
back? If y'all back, if you can cut your cameras on so I can make it go through a little quicker. Number 1, Cassidy, which of the following are the indications for oxygen therapy? Why do we give oxygen?
To treat hypoxemia, to decrease the work of breathing, and to decrease the work of the heart.
Excellent. Decrease hypoxemia, decrease the work of the breathing, and the work of the heart. 1, 2, and 4. 1, 2, and 4. All right. Number 2, Sydney, oxygen toxicity is caused by what? What causes oxygen toxicity? Which one of those is best choice? O2 toxicity. Something specific about it. Which one of those
Is it B?
No.
Oh, then it's A. Or not.
Let me see. If O2 greater than 50 for more than 24 hours, we start seeing toxicity.
Okay.
Okay. Make sure you guys know the other hazards as well and how they are manifest. Oxygen toxicity is one. Absorption atelectasis is one. RLF or ROP is one. And O2 induced hypoventilation. All 4 of those are hazards, and you need to know the difference between them. Okay. All right. All right. Number 5. Michaelin, number 5. Which of the following is true of a low flow system?
A, as
A.
VT increases, FiO2 decreases.
Excellent. That's the only one that's true, and that's in that list. As the tidal volume increases, the FiO2 is going to go down, right? When you got a low flow system. So if I got that nasal cannula in my nose and I start breathing real deep and more volume, then the FiO2 is going to start going down, right? Only in a high flow system can I guarantee the FiO2, no matter how I breathe, right? No matter how much volume I'm moving, in a high flow system, the FiO2 will remain the same. All right. Number 8, charisma. When using a nasal catheter, how often should it be changed?
Every 8 hours.
Every 8 hours. What else should I do? Courtney, what else should I do? Not only change it every 8 hours, but what else should I do with the nasal catheter?
You have to clean it.
Okay, you may have to clean it, but you need to change nares. Right, alternate the nares. All right, Courtney. Let's see here. Number 9, Courtney. Which of the following is true of a non-rebreather mask? I'm talking about the non-rebreather. That's the one that has the valves on one-way valves all the way around, right? What's true of the non-rebreather? So there's one of these, or maybe a couple that you can get rid of. What's true of a non-rebreather?
Is it D?
Which one?
D as in dog?
Dog, let's see. Well, the first 1/3 of the gas goes into the bag, you know that's out because it's a non-rebreather, right? So none of your air going in the bag. So 1 is out. So that gets rid of C, that gets rid of A. Number 2 says oxygen flow rate should be adequate enough to keep the bag from collapsing on inhalation. Yes, 2 is definitely in it. Has a one-way valve between the mask and the bag. Yes, so 2 and 4 are definitely in it. Which one did you say?
D
D
as
is
in
dog,
dog.
right?
Yes.
Okay. So 2 and 4 are definitely in it, but there is no 2 and 4. So 2, 3, and 4. That'll be your best choice. Because it does give 70 to 80, but it can even give more than 80, right? It can give out, almost 100%. But that's your choice. 2, 3, and 4. All right. Let's see who else we got here. Kelsey, is Kelsey you with us? Let's see her. I think she's not with us. Okay. Heather, are you with us?
Yeah, I'm here.
All right. Number 11, a polographic oxygen analyzer actually measures what, Heather? The polographic oxygen analyzer measures what?
Is it B?
Partial pressure. Let me see. Number 11. Oh, this one got the answers on it. Number 11, what is it, y'all? I don't have the answers with me, and I forgot.
I got B. That's what I thought.
Yeah, I think it's B.
Partial pressure? Okay.
Yeah, B would be the best one because in the notes it said the greater partial pressure of oxygen.
We'll check it to make sure, okay, because I don't have my answers in front of me. Number 12. Michael, and number 12, blue silica gel crystals are used to do what?
B, dehydrate the gas being measured.
Good. All right. Lori, all of the following are sources of error in the readout of an oxygen analyzer except which one? All of these are errors, sources of error, except what? Torn batteries, torn membranes. No, that is a source. Anybody else? For number 13.
C, a 3-to-1.
3-to-1 venturi orifices. Now, what FiO2 is 3-to-1?
Oxygen.
No, we talking about oxygen. What percentage? What percentage FiO2 is 3-to-1 air to oxygen ratio? That's what they're saying right there. 3 parts air to 1 part oxygen venturi orifice. That's what that's saying right there. So 3-to-1, I told y'all 3-to-1 was always what FiO2?
Is it 40?
40. Yep, 40. Good. So that's, that's not part of this problem, but it's good to be able to recall that, guys. You know what I'm saying? You need to know that 40% is 3-to-1. Okay. So that has 4 total parts. Okay. But yeah, that has nothing to do with the oxygen analyzer. Nothing at all. Cassidy. Let's look at this right here. During treatment rounds at lunchtime, you see a patient eating with his prescribed, I don't know how this got, with his prescribed 28% venturi mask off. So he's sitting in the bed and he's supposed to be getting 28%, Cassidy. 28% is what he's supposed to be getting. He got it in the venturi mask, but he has it off so he can eat his chicken. Okay. He started complaining of shortness of breath. Remember, dyspnea means shortness of breath. And his nail beds are showing cyanosis. Which of the following physician orders would you obtain? What would you want to do, Cassidy, at this, since this is happening? A venturi mask is what he's been using at 28%, but he takes it off so he can eat. But when he takes it off, he gets short of breath, he starts getting cyanosis, right? So what would you do, Cassidy?
Is it C?
Okay, nasal cannula, 6 liters is a lot. He only needs 28%, Cassidy.
So then B.
B, good. Nasal cannula at 2 liters during meals. So, Mr. Smith, when you want to eat, we'll put you on a nasal cannula so you can still get his 28% and he can eat. Okay? Good. All right. Courtney, number 17. Which of the following, the reason the flow rate must be greater than 5 on a simple mask, on a simple O2 mask, right? That's this right here. This is the simple O2 mask. Why does it need to be greater than 5, Courtney? Remember, the flow rate is 5 to 8 on a simple O2 mask. Why does it have to be at least 5?
Is it B, to prevent CO2 accumulation?
Good, to prevent CO2, because this is a mechanical reservoir space. This mask is going to conserve CO2. If that flow is not at least 5, it's not blowing it and flushing it out, so he'll build up CO2. Good. All right, everybody, number 19. Number 19. In an emergency room, the doctor has you draw an ABG on an unstable COPD patient before placing him on a nasal cannula at 4 liters per minute with the following results. Now, he's an unstable COPD patient, and before you put oxygen on him, this is his ABG. Okay, before you put him on oxygen, his ABG was pH of 7.35, CO2 of 52, a PaO2 of 46, and his bicarb was 32. On returning to the emergency room, the doctor has you redraw the ABGs with the patient on the cannula, right? that you put him on, right? So after you, that's the first, this is the first ABG here, okay? This is the first one up here. Then, which is okay for a COPD, all right? I mean, his O2 is a little lower than it should be. We can bump that up, but you put him on 4 liters, right? 4 liters nasal cannulas, what you put him on. Now look at his results. pH of 7.23, CO2 of 70, a PaO2 of 78, and a bicarb of 32. What do you want to do now? He's an unstable COPD. So he's breathing unstably, okay? And so you went and got an ABG right quick. You saw his ABG, which is 7.35, 52 of CO2, and his O2 was 46, and his bicarb was 32. For a COPD patient, right, this is fully compensated respiratory acidosis with moderate hypoxemia, right? Okay. You went and gave him 4 liters of oxygen through a nasal cannula when she's unstable, okay? And then you get another ABG, and now he is 7.23, CO2 of 70, PaO2 of 78, and a bicarb of 32. What should be done? Y'all can put it in the chat. These are the kind of questions you're going to start getting as you go on. These are case studies. This is like, they give you all this information. They might have gave you his hemoglobin and all of that, right? And they may ask you several questions from this one paragraph. You got to be able to start putting stuff together. You are the clinician. So you might, well, hold on, doc, this is what we need to do. Or do you do nothing at all? Look at it again, Michael. This is an unstable COPD. Unstable. Heather, look at it again. Stephanie, good, Stephanie. Good, Michael. That's what needs to be done. What you think, Courtney? What you think, Lori? What needs to be done? What has happened? That's the main thing you got to figure out. What has happened? What kind of patient do I have? I gave them oxygen. Now what has happened? So when you're putting your therapy skills together right here, knowing what to do. What have you caused? And what do you need to do? And once you find out what you need to do, you got to figure out what device will do that for you. Good, Maria. Courtney, look at it again, sweetie. We're going to break it down in a second. Cassidy, look at it again. Cassidy, there you go. Good, Cassidy. All right, so let's break it down. The answer is C. Okay? Now let's break it down. So why is it C? Well, You came to the ER and the patient wants you to get an ABG on an unstable COPD patient. Automatically, I know that he's unstable. So what type of oxygen flow device do I use on an unstable patient? High flow or low flow?
High flow.
High flow, because low flows have to be less than 25, 300 to 700 tidal volume, and constant ventilatory pattern. This patient is unstable. Okay, he's unstable. So you cannot use, first of all, you cannot use a low flow device. Okay, so a nasal cannula is already a low flow device. So that's already not what we want to do. Okay, a non-rebreather is a low flow device. A partial rebreather is a low flow device. Okay, that's first of all. Now, when you came to him, before you put him on anything, he was on room air. Okay, his pH was 7.35, which is normal, but in the acidic side. Okay, his CO2 was 52, which is normal for a COPD, or they retain CO2. Okay, so that's okay. His PaO2 is 46. Now we want them to be hypoxic, but that's a little much. Okay, so he's hypoxic. He's moderately hypoxic. His bicarb is 32, which is high, right? But it's compensating for the CO2. So that is a normal blood gas with moderate hypoxemia. All right. But he's short of, he was short of breath or whatever the problem was. Let's see, unstable. He's unstable. Now you come back. You come back to the emergency room and the doctor wants you to redraw the ABGs while you have put him on 4 liters of nasal cannula. So you put him on a nasal cannula at 4 liters per minute and he's unstable. Okay. Now look what you've done. What happened to his pH?
It
It
went
became
down.
more acidic.
It became more acidic, right? More acidic, right? What happened? Look at his CO2. What happened to his CO2?
It became
Went
more
up.
acidic.
It went up. It became more acidic. So he's breathing slower. Okay. He started breathing slower. So his pH started dropping. CO2 started going up. Look at his PaO2. You got his PaO2 up to 78. Right? 78. That's almost normal. Right? And his bicarb still at 32. So what would I do? First of all, what have you done? What have you done by putting him on that oxygen? What is that hazard called? What have we done to him?
You hyperventilated him.
Hypoventilated, right? Oxygen-induced hypoventilation, right? Just like when you go and cut granddaddy's oxygen up, he start breathing slower and slower and slower, right? And if I'm breathing slower and slower and slower, my CO2 is building up, okay? That is classic clinical oxygen-induced hypoventilation. Okay, that's what you've done. He was unstable, which means he could have been breathing fast or he could have been breathing really slow. Okay, but you have him on 4 liters, and now his PaO2 has jumped way up from 46, way up to almost 80. Okay, and you see that he's starting to hypoventilate. Right. So what do you need to do? Now, A, do I turn up the oxygen even more? No, I'm gonna kill him. Right. B, change to an O2 mask. No, a simple O2 mask is a low flow device. Look at D, place on a partial rebreather. No. First of all, you don't use a partial rebreather at 4 liters anyway. Partial rebreather must be 8 to 10. So that's no. Okay. And then do nothing. He's fine. No. You place him on a Venturi mask at 24% because a Venturi mask is which type of device? High or low?
High.
High flow. The Venturi mask is a high flow system, and I can guarantee the FiO2 in a high flow system. So I put him on 24%, and I don't care how he's breathing, how unstable he is, he only gonna get 24%. That's what you have to do. Anytime you have somebody who is unstable, they must be on a high flow device. Okay, we said that several times. You have to know that. You have to know that some people qualify for low flow, some people qualify for high flow. So go back to that lecture, study, because this questions like this on the final. Okay, that's why the final is so difficult, because it's a combination of things and they're heavy questions. But this is something that you know. If you've learned all of this, but just have to be able to put these things together. I have to look to say, okay, this is his ABG first. This is what kind of patient do I have? He's unstable. So I'm already in my mind, okay, unstable, I need a high flow device, okay? So, but the doctor wanted me to put him on a 4 liters nasal cannula. And after I did that, he started to become very, very acidic. He's going into respiratory failure because he's not getting the CO2 off. His PaO2 has jumped way up, so that's the problem, right? I gave him too much oxygen and on a low flow device. So I need to switch a little less oxygen and put him on a guaranteed FiO2 device, which is anything in this choice that would have been high flow, you would have picked it. Any high flow device would have been right, okay? So that is how you have to be able to put the stuff that you've learned together on these case study type questions, okay? All right. But good job. For those that got it right off, good job. That's what you got to do. You look through your choices. You got to know, what do you got? What have you caused? Did you cause a problem? And how do you fix it? Why did I cause that problem? The doctor was wrong. He wanted a cannula on an unstable COPD patient. He should have never, or she should have never asked for that. You have to be able to say, "Oh, doc, we can't do that. I think we should do this." You are professional just like they are, okay? All right. Like, for instance, number 21, low flow O2 delivery systems employed in respiratory care include all of, except which one? So which one of these is not a low flow system?
C.
C, the air entrainment mask. Air entrainment is the Venturi mask, the Venturi principle. Aerosol this, aerosol that, right? They all hook up to a water bottle and have the Venturi gate on the top where I can turn the FiO2 how I want it. That's the high flow system, air entrainment. So remember that air entrainment is your Venturi system, whether it's on a mask or aerosol setup. That Venturi gate, where it sucks in outside air, is air entrainment. It gives you an air entrainment ratio, which is air to oxygen, right? The parts. That's all Venturi. And it is a high flow system. The nasal cannula is low flow. Nasal catheter, low flow. Transtracheal catheter, low flow. Partial rebreather, low flow. Non-rebreather, low flow. Okay? The only one in this list that is a high flow system is the air entrainment mask, aka Venturi mask. Okay? And the aerosol trach collar, aerosol T-piece, aerosol trach collar, whatever, face mask, all of those use the air entrainment system, which is the Venturi system, and it makes it high flow. Okay? You've got to be able to understand that. All right. A couple more, we'll be done. Okay, look at number 22. Same concept. To ensure that a stable FiO2 under varying demands, what must an O2 delivery system do? What must it be able to do to ensure FiO2 no matter what the demand is, whether a patient has a large demand or low demand, whatever? What should it be able to do? What must it be able to do to ensure a stable FiO2? Remember which devices can do stable and which can't. Some low flow devices cannot guarantee a FiO2, period, right? Only high flow systems. So high flow systems must be able to do what? What you think, Charisma? What must a high flow systems be able to do? We talked about high flow system. It must be able to do what?
See,
No, we don't want them to be at least equal to their peak flows. What do we want them to be? They must be able to what? Anybody else?
B, provide all the gas needed by the patient during inspiration.
Yes, the high flow system will provide all the gas needed. Remember, it meets your patient's what? Demands. High flow systems will meet all of your patient's demand. I don't care if he wants whatever. We can meet his demand, right? That's what we want to do. That's when we look at our system to find out, are we meeting and exceeding? Remember, make sure you remember how to find the demand, right? Demand is 3 times the minute ventilation. Then you set up your system and see if you're meeting his demand, right? So if Mr. Johnson has a demand of 50 liters per minute, then my total flow of my system that I set up must be at least 50. Otherwise, I am not meeting his demands. Okay? All right. All right, so let's look at that then. Let's look at high flow and see if you're meeting your patient's demand. And then we'll be done. We'll do a couple of these and we're gonna be done. Have to make sure y'all going back and studying all this stuff. Can't just focus on the unit that you're on. Said that several times. All right. Let's look at our high flow, low flow, and our demands and total flow. All right. Mr. Smith has a frequency of 24 and a tidal volume of 520. First of all, what is his minute ventilation? Second of all, what is his demand? Okay? So I need to know first. And then the system that you want to, oxygen system that we're going to have him on is we got him on a 28% aerosol face tint at 15 liters per minute. So the next question I'm going to ask is, what is the total flow of this system? And lastly, demand met? Yes or no? So work that out, and then I'll call on you to see what you got and how you worked it. You got to remember, I'll give you this. Demand is 3 times the minute ventilation. 3 times the minute ventilation is the demand. This is what you got. Smith. And so you might have a question with all that you just had with his ABG, post ABGs. Then they give you this, and they give you his hemoglobin, his white blood count. All that might be in the problem. You just need to pull out what you need to answer these questions. They may give you an ABG and then ask you what is his dissolved amount, his total amount, what's his minute ventilation. You know, it's a lot of things, guys. You got to be able to pull out what you need and go on about your business. So of course, you got to know what the formula is for minute ventilation, because they're not going to give you all of that. Give you a minute to work on that, then we'll start going through. All right, here we go. First things first. All right, Cassidy, what is the minute ventilation?
12.4.
Okay, 12.4, good. Minute ventilation is 12.4 liters. Any questions about how they got that? Anybody couldn't get that? All right. Now, so Charisma, if his minute ventilation is 12.4, then what is his demand? You should step away.
37.2.
Okay. 12.4 times 3, 37.2. So that is his demand. He said he got to have at least 37.2 liters per minute coming to him. That's his demand, right? All right. So now we need to know, are we meeting or exceeding his demand? Did we meet it with this device? He's on a 28% aerosol phase tent at 15 liters per minute. So Courtney, what is the air? First of all, we're going to try to find total flow. First, let's find the air to oxygen ratio with the magic box. Okay. So with the magic box, Courtney, what goes in the middle?
28.
28%. We got 100 right here and a 20 right here. Courtney, 28, well, 100 minus 28 is what?
72.
72, and 28 minus 20 is what?
8.
8. So 72 divided by 8 is what, Courtney?
9.
9. Okay, so 9 parts air to 1 part O2. So that's the air to oxygen ratio right here. Okay, now 9 parts air, 1 part oxygen. So the total parts, Courtney, is what?
10.
10. 10 total parts. 9 plus 1. 9 parts air, 1 part oxygen. 9 plus 1 is 10 total parts. Now, to find total flow, we have to do total parts times the liters per minute. So 10 times 15, Courtney, is what?
$150.
150. So our total flow is 150 liters per minute. So I asked a question to you, Courtney. Did we meet his demand?
We did.
We did, and we exceeded it. We met
Yes.
and exceeded it. So yes. Okay, that is demand, and did I meet? You got to find the patient's demand, and then you got to do your setup to find out if you met it or not, right? All right, let's do another one. This time, you have Mr. Tate. Mr. Tate has a rest or frequency of 32 and a tidal volume of 650. That is what he's breathing. And you have him set up on a 40% aerosol T-piece at 12 liters per minute. I need to know his minute ventilation, what is his demand, his total flow, and did you meet his demand, yes or no? But I mean, that was stupid. That's, you know what I'm saying? She thought she was, I said, Mom was not going to run out of gas with her in there. You know what I'm saying? So we went out there, that's what my gas tank, doing all that. Ooh, too much. So what you would, you know, you could have hurt yourself. Anything, you know. So last the connection, what she's doing. Let her think that all day. You know what I'm saying? That'd be the best. All right. Let's see who I've got in here. Heather, are you with us, Heather?
Yes, I'm here.
All right. What is the minute ventilation, Heather?
20.8.
20.8. Good. So the minute ventilation is 20.8. All right, liters. All right. So if his minute ventilation is 20.8, Lori, what is his demand? Okay, 20.8 times 3, 62.4 liters. Okay.
And Mr. McCarthy,
Yes.
if we round it up, like I said 21 instead of 20.8, and still that'll be like close to that number. Is that okay?
That'd be all right because your answer choices will be definite. Your answer choice is not going to be that close to have to choose between you round it or not. You'll know
Okay.
the definite answer. Yeah. Okay, so total flow. So Heather, if I'm trying to find out what the total flow of my device is, then what do I put in the middle here for my magic box?
40.
40. Okay. So 100 minus 40 is what, Heather?
60.
60. And 40 minus 20 is what?
20.
20. So 60 divided by 20 is what, Heather?
3.
3. All right, so we know we have 40%, which is always 3 to 1. Now, what's the total parts? Heather?
4.
4. And so if the total parts is 4, then what is the total flow?
48.
48 liters per minute. 40%. 40% is always 3 to 1. All right. So his total flow is 48 liters per minute. That's the total flow of the machine that Heather has him set up on. So Heather, if he demands 62 and you only give him 48, are you meeting his demand?
No.
No. You're not meeting demand. So what you have to do, guys, knowing the relationship between FiO2 and volume, right? Knowing the relationship. If we need more flow, right? We need more volume. What do we have to do with the FiO2 to get more volume? When you increase the volume, what happens to the FiO2?
It goes down.
It goes down. So we need to come down on the FiO2, right? If we come down on the FiO2, that's going to give us more total flow, right? So think about this. I'm not going to do a whole nother problem. But if 40% is 3 to 1, which was a total parts of 4 times 12 gave us 48, what happens if we change that to 28%? 28% gave us a total the air to oxygen ratio of 9 to 1, right? 28% was 9 to 1. That's what Courtney just did. 28% is 9 to 1. So 9 plus 1 is 10 total parts, right? Total parts times 12. Then we would have a total flow of what?
120.
That will bump our flow up to 120. Now are we meeting his demand? Yes. So when you go down on the FL2 decreases, then the total flow increases. Okay? If you don't change this liters per minute, if you leave it at 12, I'll just come down from 40 to 28. Remember, they don't always need the oxygen. Sometimes they just need the flow. Okay? Sometimes he just needs the flow, not necessarily always oxygen. Okay? Don't forget that. Remember, if you feel a little short of breath or you get stuffy and you're in your car and you start feeling short of breath or whatever, what are you going to do? What's the first thing you're going to do? Roll down the window. But the FO2 outside is the same FO2 in the car, right? So it's not an FO2 situation. You needed some air, right? You're going to find a lot of your hospital patients, they'll have a fan in their room. They want a fan. They want some type of air condition or something, because sometimes you just need to feel it. Okay, you need the flow. So don't always think that they need it. So I can't come down on oxygen. They can't do that. Yes, sometimes you can. Just depend on if they need the flow or not. But if they need high flow, Michaelin, if they need high flow and high oxygen, what kind of setup? Do you remember what kind of setup we have to use? In order to achieve that, what we have to use?
You would have to use the double one where you have the oxygen and then you have the air. And
Yeah, we
use
have
it.
to have two. Called the tandem, right?
Tandem.
Sometimes we have to have the tandem because this patient needs a lot of oxygen and a lot of flow. So now we need two separate systems coming at one, right? That's when I had the one hooked up to the oxygen and I had the other flow meter bleeding in to give me more flow, okay? So that's where you'd have to go with a tandem. Good. All right, guys, so that's going to end it for today. It's 4 o'clock. We have covered A all the way up to G. Is this G? Yeah, G. Tomorrow we will take on humidity. We're going to talk about aerosol and humidity. We're going to talk about pharmacology and lung inflation. Okay, those are the 3 things we will cover tomorrow during review. It's best to try to come to campus if you can, but if not, be live and direct like most of you were today so you can answer these questions. We're going to go into some more of those questions. If you have questions, we can ask them then, okay? And that's how we'll do this. Again, the old reviews are also in the module, okay? They're also in the module, and I think I even changed the date on them. And I'll throw this one in there. So you have ample review, okay? Everything is in the module from A to J. It's in the module. Today's lesson will be in the module. The homework has already been set. It's in the module for 3/2/21. So make sure you go on there tonight and knock out that homework assignment for your attendance today. And I will see you guys tomorrow. Don't forget, in your announcement section, there is important dates for the makeup labs and the oral exam and the final exam. All of that is in that lecture. Make sure that you look at that, and it says important dates. That's how it's measured, or it's labeled in the announcements. So make sure you look at that. And I will see you guys on tomorrow, same time.